unique webinar series, Practice Pulse in Hypertension. And this is the second edition of Practice Pulse in Hypertension. And today we are going to discuss about interesting topic, that is the chronotherapy in hypertension. And to guide us, we are having a course director, Dr. J.C. Mohan sir with us. He is the chairman and head of the cardiology at Jaipur Golden Hospital, New Delhi, and has a vast clinical experience in the cardiology. He has a keen interest in the research and published more than 250 research articles in various index journals. So now I hand over the session to Dr. Mohan sir. Over to you, sir.
Thank you, Dr. Mithlesh. Good evening, ladies and gentlemen. Welcome to this series of webinars on arterial hypertension. And last webinar, we discussed how to manage difficult to control hypertension. And an extremely interesting case was presented by Dr. Soumitra Ray, where the obstructive sleep apnea was the cause of resistant hypertension. Today, we have again an extremely talented and very senior intervention cardiologist, Dr. Jagdish Hiremath, who is the director of intervention cardiology, Ruby Hall Clinic, Pune, who is going to deliberate upon again a very interesting, relatively new and contentious topic of chronotherapy in hypertension. How solid is the evidence? Dr. Hiremath, I have known him for a very, very long time. And not only he is an accomplished intervention cardiologist, he is also a great human being, a great teacher, and he regularly conducts lots of academic programs in Pune on both non-invasive and invasive cardiology and clinical cardiology. I am also told that he regularly does some the ECG workshops, which are large, attended in a very large number. With those words, and I don't want to say more because most of you know Dr. Hiremath. He has been there on this scene of cardiology for several decades. And he is going to take us through chronotherapy of hypertension. How solid is the evidence? So the point is that there is talk going on now that to get maximum cardiovascular and renal protection from anti-hypertensive drugs, these drugs should be aligned with endogenous circadian rhythm. If we want to align it with endogenous circadian rhythm, this is what is called chronotherapy. And it's not only true for long-acting, short-acting drugs, it's also true for long-acting drugs. Dr. Raymond Hermida from Madrid, who works in the Institute of Bioengineering and Chronology, has been pioneer in this direction. This whole thing started from a simple fact that before Dr. Raymond Hermida actually became popular in this thing, we realized right in 2001 that HOPE study, where ramipril caused only a 3 millimeter decrease in systolic blood pressure, was causing nearly such a big, actually close to 25 to 30% reduction in all events, 22% all in all. And the ambulatory blood pressure monitoring suggested that since the drug was given as an evening dose, some patients where ambulatory blood pressure monitoring was done showed a nocturnal fall of blood pressure of 17 by 8 millimeter, a diurnal fall of something like 10 by 4 millimeter, although office blood pressure only fell by 3 by 2 millimeter mercury. And it was suggested that it is the chronotherapy which is actually accounting for that large difference, that large benefit you are getting from ramipril, and that ramipril does not have pleiotropic benefit. The entire benefit is based upon its anti-hypertensive efficacy, especially for nocturnal hypertension. That was the whole basis on which actually chronotherapy has gained currency over a period of time. Last year, Dr. Raymond Hermida published his last series of 19,000 patients called HYGEA study, which tried to emphasize that evening dosing of antihypertensive is very, very beneficial for cardio and renal protection. To take us through the entire gamut of chronotherapy in hypertension, to discuss the pros and cons, the caveats and precautions, the amount of evidence and the robustness of evidence, and what more should be done. We have Dr. Jagdish Hiremat. I will now leave this podium, leave this space for Dr. Hiremat to take us through this entire business of chronotherapy in hypertension and the robustness of evidence which is available as of now. Dr. Hiremat, please.
Thank you, Dr. It's always a pleasure to be associated with you on the podium. And it's also because he being such a strong academician, any question that gets unanswered from my side, I am sure he has the vast knowledge to answer all your questions. Chronotherapy is really a new topic, and in fact, this is my first time I am addressing chronotherapy in my talks. So we have to think whether it is not enough evidence of red or moderate quality evidence or robust evidence. As we go along, we'll see where chronotherapy stands as of today. Some basic things we have to see before we go on to chronotherapy proper. Number one, hypertension must be controlled. It's a very basic statement everybody knows. But I want to show you a person who died and had bilateral renal artery biopsies, one on his right side, one is on his left side. He had unilateral renal artery stenosis on the left side. Because of the critical renal artery stenosis, the kidney got exposed to normal blood pressure beyond this stenosis all his life, and it remained well, whereas the one which got exposed to his hypertension had developed nephrosclerosis. This is a very strong visual evidence to say that you need to control blood pressure very well. Having said that, there are a number of blood pressure goals that we keep discussing ad nauseum, and one is always confused. I am also confused as to how many guidelines to remember, how many cutoff points to remember, what is called hypertension, pre-hypertension. So I have made it simple for myself. All blood pressure patients I want to control below 135, below 85. If my drug treatment brings the patient, say, to 132/82, I'm happy. But if he remains above 135 or above 85, I would get him more drugs to bring him below that. And that covers practically all the guidelines that we have. But it doesn't stop over there. Now we think of the Hope Asian Network highlights that BP control must be 24 hours. In fact, this particular study wants us to give a zero cardiovascular morbidity mortality in Southeast Asia. And for that, they advocate a 24-hour BP control with a triad of circadian rhythm, BP variability, and all these three will lead to a cardiovascular protection. So it says that 24-hour BP control aim towards achieving a zero CV morbidity mortality. But to do this, whether to control blood pressure or control 24 hours, there are a lot of barriers, as we know. One of the not so thought of barriers is the circadian rhythm. That means everybody, a normal person, dips about 20% at night. So it's called the nighttime dipping. So a normal dipper goes like this, and then he has an early morning surge, which is quite normal. This surge can be exaggerated by cold, by exercise, by smoking, alcohol. All this we know very well. There could be nighttime surges related to obstructive sleep apnea, arousals, REM sleep, or nocturia. And there are some people who would be non-dippers. They don't dip at all. They remain non-dippers at night. There would be negative dippers or risers. They also have problems. And there would be extreme dippers. Fortunately, the extreme dippers are not many, and we don't have to talk about them, at least as of today. But nighttime dipping will depend on all these factors listed here. So not only we have to control blood pressure very well, but also control this dipping part, which is physiological, and take care of the early morning surge. And we all know that non-dippers have worse cardiovascular outcomes as compared to the dippers. Now think of a situation where is a dotted line is a untreated hypertensive. He follows the circadian rhythm and also has early morning side. Normotensive individual is lower on either side and his early morning surge is also lower. But look at the treated hypertensive. He would remain lower than the untreated hypertensive. But in the morning, he will have early morning surge also. So in order to take care of the treated hypertensive and bring him down to this level of normotensive individual, which would mean we have to take 24-hour control and control this early morning surge also, which would be talking in terms of controlling the circadian pattern of blood pressure. Indian study, large study of almost 39,000 ambulatory blood pressure monitoring. These are blue bars are normal individuals and red bars are hypertensive. So normal dipping is seen only about 36% of the hypertensives. Non-dippers become very high in hypertensives. Reverse dippers are high in hypertensives, and extreme dippers, fortunately, the population is lower. So if you look at this graph, we know that nighttime something is going wrong and we need to control that. And the other aspects were about obstructive sleep apnea, which I want to brush over as of today. Another important this thing, whether it is useful of ambulatory blood pressure in measurement of hypertension management of India, the ambulatory India ABPM study, which says that if you look at this statement, isolated nighttime hypertension in these people was very high, about 10 to 11%. And we know that isolated nighttime hypertension would mean uh, uh, high cardiovascular events. In India, we have both the problems, high prevalence and poor blood pressure control. And so the chronotherapy, if hypertension becomes important, we have to control blood pressure first. We have to control it well because Indians have early development of coronary artery disease. And also we need to control it for 24 hours. So all these pressures would mean we have to think of chronotherapy and think of pressure. So is an evening dose of antihypertensive therapy ready for prime time? That means this murmur started in 2014, in which it was meta-analysis was done of many trials. The slide is a bit busy, but I want to read you or read only the red boxes to you. On the left side, nocturnal BP levels predict CV risk. The lack of nocturnal decline in BP is linked to high CVD risk. And on the right side, a lower box, heart rate demonstrated a statistically significant 37% lower risk of favor of evening dosing. That also is an important factor to remember based on this analysis. And then there is a lot of evidence which started coming to the last trial mentioned by Dr. Mohan. There were many other trials. Spain, especially, people were quite against this night dosing, and we heard speakers from Spain which saying that they don't think there is early morning surge also, but there is a lot of evidence related to that. So in 2018, this appeared that, let's say group 2 is the group who receives nighttime dosing. So group 2 have less sleep systolic to diastolic mean, sleep time relative systolic to diastolic decline, prevalence of non-dipping blood pressure, hazard ratio of total events, and increased BP control, and increased survival compared to group 1. Ingesting calcium channel blocker, beta blocker, or ARB at bedtime compared to morning reduced the CVD risk. There was no significant difference in ambulatory blood pressure monitoring between morning and bedtime aspirin admission because it's a long-acting drug. Well, it doesn't make a difference, but hypertensive medication made the difference in chronotherapy of hypertension. Multiple trials running from 2013, 17, and again they also said that reduced BP more predominantly at night, control 24-hour systolic and diastolic blood pressure. Participants with monotherapy were unresponsive to bedtime dosing, but their BP was controlled by addition of second drug at bedtime. Morning administration reduced the brachial and central systolic and diastolic blood pressure, and bedtime administration reduced the central diastolic blood pressure, again probably responsible for the cardiovascular event. Bedtime dosing reduced non-dipper, reverses dipping pattern, and cardiovascular risks as compared to group 1 and group 2. Many evidences go on, and so many times it is easy to remember the punchline that reduce the morning surge from baseline, no significant change in dipping status, 24-hour mean blood pressure. Compared to baseline, groups 1 and 2 showed decreased 24-hour night time, morning time, pre-awake morning, and evening home systolic oblique diastolic blood pressure, and home BP variability. Group 2, that is those who took blood pressure tablets at night, showed reduced high sensitivity troponin T, NT-proBNP, and urinary albumin creatinine ratio. And there was no difference in ABPM between polypill dose time period 1 and 2 compared to individual agents. So we'll skip that for the want of time. The meta-analysis compared of 5 clinical trials that administered antihypertensive medication in the evening compared to 170 clinical trials with dosing in the morning reported a significant 48% reduction in relative risk of adverse CV events in patients ingesting the medication in the evening compared to that in the morning. So on one side, you have a very large number of trials. The other side, the number of trials are small, but the difference in CV is dramatic. And that's why chronotherapy of hypertension is now established. Meta-analysis of 3,500 patients of obstructive sleep apnea also showed a remarkable difference because, as we heard, obstructive sleep apnea is one of the reasons of high surges at night and also resistant hypertension. So I'll skip these trials because they all give the same thing. And the main trial or bone of contention is this HYGEA chronotherapy trial, which has appeared in the Clinical Research Hypertension Journal. And it said that bedtime treatment improves cardiovascular risk reduction, the chronotherapy trial. It produced a lot of, shall we say, ruffled lot of feathers. It has appeared in the European Heart Journal in 2019. And it clearly showed that it had wide publicity because it was a significant change from the dosing of antihypertensive medicine from morning to night. And essentially, again, rather we can go through the figure and the flow diagram, but on the right side it mentioned, in this multi-center controlled prospective endpoint trial, nearly 19,000 hypertensive patients were assigned to ingest an entire daily dose of more than one tablet at bedtime, half of them or all of them on awakening in the morning. At inclusion at the every scheduled clinical visit, at least annually, throughout the follow-up of many years or more than 6 years, ambulatory blood pressure monitoring was performed for 48 hours. And it clearly shows, if you look at the hazard ratios, on the left-hand side, bedtime better, on the right-hand side of the vertical line, awake time better. So whether it is total events, total CVD events, CVD outcomes, stroke, coronary event, everything is better when night-time dosing is done. So this is almost a take-home figure wherein adjusted hazard ratios were compared, and this became one of the talking points of the European Heart Journal, European Heart meeting also. The routine ingestion of hypertensive patients of more than one prescribed BP lowering medication, as opposed to upon waking, results in improved blood pressure control, significantly enhanced decreases in asleep BP, and increased sleep time relative BP decline, that is BP dipping, and most importantly, markedly diminished occurrence of major cardiovascular events. So one started thinking whether one has missed a point for all these decades or years we are treating hypertension. Just a shift of a morning time BP tablet to night time, it would have made so much difference to the humanity as such. But things are not as rosy. There are other two trials which I have to mention, whether it is a MAPEC trial or a tying trial in UK, which is actually happening now, which will also show further light on this chronotherapy. Of course, chronotherapy came to a lot of discussing issues as well. There were a lot of criticism related to the way the trial was conducted. Such negative remarks are there for the trial sometimes that we feel that even politicians could be better in making these comments. So you could hear all these remarks when you read for yourself. I don't want to bring it into the, but what was questioned in this devil's detail is, what was questioned is the methodology, the over dipping and exaggerated form of the nighttime dipping, increased incidence of angina events at night, silent cerebral strokes and infarcts, all these were not considered in this. Then if it was so successful, then why was the trial continued beyond 6 years is also questioned. And somehow it is, the murmur is that the results are too good to be true. And that's why the 48-hour ambulatory blood pressure monitoring, if you have to do it for so many patients for so many years, then so many ambulatory BP monitoring were not performed also, is a lot of discussion related to that. However, in Medicina Clinica 2020 highly favors HYGEA trial and also favors the chronotherapy related to that. Overall, the thought process today is that nighttime dosing improves 24-hour blood pressure regardless of the comorbidities. It will improve the control. It will reduce BP variability. It will reduce the early morning surge. It will bring in physiological control of blood pressure by producing a 20% dipping at night. But despite this large evidence, only ADA has approved it in its guideline as a nighttime dosing as important. No other institution has agreed or put it in their guidelines. So I would say that absolutely there is no harm done, is everybody says. Whether it is useful or not is to be discussed, but loud and clear, there is thinking about it. So I thought I would have my own personal musings related to chronotherapy in the end. We have to get 24-hour control on the blood pressure, chronotherapy or otherwise. What time you give the blood pressure medicine becomes unimportant as long as you control it 24 hours. Get a good smoothness index and less blood pressure variability. Get physiological night dipping and prevent early morning surges. All of these above will improve your cardiovascular outcomes. Today, there is enough evidence that chronotherapy for hypertension works, despite the fact that there are negative comments related to this large trial. There is hardly any debate about timing if 2 antihypertensive drugs are given. Suppose 2 times are given a BD dosing of a same drug, then there would not be so much discussion related to that. But when it comes to a fixed drug combination single pill, it would be prudent to give it at night so that dipping takes place, early morning surge is controlled. And for all this, the first 16 hours of the pill, I would say, would be more important, because maybe it's my personal thing that in the last 5-6 hours, the drugs will not act as well as they would in the first 16 hours. So if you could get nighttime dipping and early morning surge in the first part or the first 16 hours, it would be prudent. In India, a single FDC 5 p.m. dosing is what appeals to my logic, because there is clear evidence that evening blood pressure is on the higher side. So if you want to control that, a 5 p.m. dosing would be good. And it will also control the night dipping and also the early morning surge. But whether it is compliant, so whether it will be compromised or not, that we'll have to think about. Chronotherapy is more of a logical twist. All the facts were still there, but it was a logical twist by showing some figures that it works rather than a medical phenomenon. The available evidence of chronotherapy suggests to choosing the right time, that is a chrono, rather than the blanket morning dose or a blanket night dose. Chronotherapy should be practiced based on individual ABPM requirements. You might find somebody is a white coat, probably he needs more daytime dosing, or by masked hypertension, he may require nighttime dosing or something of that. The chronologic has evidence, so it has to be horses for courses. That means you choose the individual and choose the timing of the dose to be given. Thank you very much. I'll take questions later whenever Dr. Mohan permits.
Thank you, Dr. Hiramat. And where are we? Okay. Thank you, Dr. Hiramat. I think that was brief and to the point discussion on chronotherapy. I thought that let us have some discussion and then go to the case. I changed my mind because this seems to me an extremely interesting thing, and your thoughts on chronotherapy are very good, and I actually appreciate those.
I don't
We always have been thinking, how come the Dr. Raymond Hermida has been working in this direction for over 25 years. Why haven't others taken up this area to work and come up with argument in favor or against this evening dosing? You rightly said that the Hygia project is a single project. We have otherwise is a meta-analysis which, as you rightly said, Dr. Roosh and colleagues published actually in 2014. We don't have any single trial of the size of Hygia to support it or to go against it. And I would actually now like actually our panelists, Dr. Ashraf and Dr. Prashant, to give their views on it. Then we can have some questions, and then I think we can take the case at the end. And let me just say a few things about this chronotherapy business. The whole idea from where Dr. Raymond Hermida started was that renin-angiotensin-aldosterone system is more active at night, and because at night is more active because it's doing repair and regeneration, but sometimes in hypertension is more active than it should be, and that overactivity is harmful. And let us give a drug, whether it is short acting or long acting, in the evening. And he has shown multiple small studies and big studies that proteinuria is reduced much more if you give the dose in the evening. Strokes are reduced much more. He also showed that even beta blockers given in the evening can reduce chances of developing new onset diabetes by as much as 55%, which is remarkable. The others haven't been able to reproduce it. So I would first ask Dr. Ashraf to comment on that, and tell me if there is anything burning in his mind which needs to be answered, and then I'll come to Dr. Prashant. Dr. Ashraf, please.
Thank you, sir. And it's a fantastic talk. To me, there are a few concerns that I may agree that the nocturnal dipping and antihypertensive has to be started for the essential hypertension patient, majority, but few subset like elderly population, there is a concern of nocturnal decline, like falling BP that may lead to the, hidden stroke syndromes. So we have seen a lot of patients are referred from the ophthalmology unit with a history of anterior ischemic optic neuropathy because of nocturnal decline in certain over-aggressive treatment with blood pressure, antihypertensive in elderly population. So to me, this chronotherapy is wonderful for the essential hypertension rather than secondary hypertension, because majority of secondary hypertension need 2 or 3 drugs. Even for the hypertension, not secondary hypertension, the primary hypertension again, essential hypertension, majority needs 2 antihypertensive, but all secondary hypertension need more than 2 or 3 or even 4. So that cases, it is not much important. And another thing, I just want to disagree one point, because I was not present in the first the part of this series, the obstructive sleep apnea. Here, the obstructive sleep apnea, even if you give antihypertensive night, it may not decrease the decline. Our aim is to treat the primary cause with the, either CPAP or any other surgical treatment, because the reduction of the blood pressure is only 2 to 4 milliliters mercury, even if you treat OSA. So it is something beyond that antihypertensive effect on OSA patients. And one more thing, for example, if you are doing the ABPM and if you are not getting the nocturnal decline, then it's also give you secondary clue that this patient is probably either need one or two drugs, or it's a probably a part of secondary hypertension or early diabetic or early nephropathy patient like that. Just want to add.
Yep.
Dr. Bendre, your comments. Please, Dr. Jagdish Shiramath. Yes.
Yeah, I said that once you are giving BD dosing or twice a day medication, this chronotherapy doesn't discover. We are not discussing. That is one thing. And secondly, in this, there are a lot of elderly people. There are people with CKD. So the chronotherapy is not really entirely related to essential hypertension. Even these subgroups have shown benefit related. Of course, as I said, we are all astute clinicians. When we are prescribing it to an elderly gentleman, we would take notice of what happens at night and warn them against the postural hyper. When they get up to go to the loo, all these things would be taken care of. But reducing or getting the nighttime dipping seems to be the key in bringing the cardiovascular effect.
Dr. Ashraf, we have seen Dr. Raymond Hermida's work in 4 different directions: diabetes with CKD, CKD alone, elderly individuals, people with proteinuria, and people with resistant hypertension. 5 different steps. And everywhere he has shown that if with the same 3 drugs, you have a difficult to control blood pressure, shifting in the evening causes a further 10 millimeter fall in systolic blood pressure and makes many resistant hypertension responsive hypertension. I'm saying his view. He has also shown that same valsartan, when given in the morning and compared to the evening, there is a further 45% reduction in proteinuria. That is his study. As far as dipper and non-dipper is concerned, there is a study which by him says that the reverse dippers actually are reduced in CKD from 20% to 7% by evening dosing. And non-dippers are changed from 58% to 40% by giving evening dose. So there is a lot of work this gentleman has done in that area, and he has tried to address all those questions we have raised. And I think the only problem we find is that somebody has more people have to reproduce that study. Is it true for all ethnicities, all geographical regions, all types of hypertension? The point we have, and Dr. Hiramath rightly pointed out from the Pamela study, 38% of the people have regular kind of nocturnal dip. They probably would not benefit from evening dosing. There is a section will not. Then we have patients who what you call as isolated diurnal hypertension.
Night.
And that number is something like 10-15%. They wouldn't benefit because they in any case are normotensive at night. On the other hand, isolated nocturnal hypertension will probably benefit more. So that is, but fortunately, unfortunately, incidentally, that number is just 10% of the entire population. So these are some of the things which we have to keep in mind before we actually take it up routinely. If given routine, and so Dr. Jagdish Sharma rightly said that you need to actually, each patient is different, and you need to find out based upon ABPM, would this patient benefit from evening dosing or not? If is likely to benefit, you must give it. Dr. Bendre, your viewpoint, sir.
Yeah, thank you, sir. It was an enlightening talk from Dr. Jagdish. I enjoyed it. Yeah, as far as CKD is concerned, because looks like most of the studies and most of the literature have included a lot of patients of chronic kidney disease. So I would like to discuss this matter in 2 parts. One is early CKD, which we will call GFR more than 30, and one is late CKD when the GFR goes below 30 ml per minute. So that means CKD 4 and 5 and CKD 3 and above. So actually you see, sir, when most of the patients land up into advanced chronic kidney disease, they develop resistant hypertension. And most of them are on multiple drugs, and most of them are on either 2 times or 3 times dosing of a single drug. So what happens is when the patients are in advanced chronic kidney disease, they will not be controlled by even nighttime dosing. Even in the day, we have to repeat the drugs at least 3 or 4 times. So these patients actually inadvertently will be taking a lot of medicines in night also, lot of medicines in the day also. So it really boils down to a 24-hour control, because these patients are prone to go into pulmonary edema. These patients are prone to develop stroke. These patients are prone to develop heart failure. So as far as advanced chronic kidney disease is concerned, number one, most of the patients are already on nighttime dosing. They are on multiple dosings throughout the day. They have resistant hypertension. And in these patients, it is difficult to dissect the effect of chronotherapy of hypertension. As far as early chronic kidney disease is concerned, when we can do most of the preventive work, it has been shown that nighttime dosing of antihypertensive agents, number one, reduces the incidence of night blood pressure. It converts non-dippers into dippers. It reduces the morning surge. So taken all together, these three things, they lead us to reduced cardiovascular mortality and morbidity. And in reality, the bane of contention in CKD patients, especially early stage CKD patients, is cardiovascular disease. It is not chronic kidney disease. It is not progression of chronic kidney disease. If we were to look at the 5-year mortality of patients of CKD, we would find that they are not going into progressive renal disease, or they are not going on to dialysis, but most of them are dying because of cardiovascular disease. So really, the cardiovascular disease is the important target to hit, and prevention of cardiovascular events is the target to hit in patients of chronic kidney disease. And there is a lot of data which shows that when the GFR is more than 30 and the early stages of chronic kidney disease, chronotherapy definitely would be a big step in this regard, because it also reduces proteinuria, it protects the kidney, and physiologically, as you have rightly pointed out, the renin-angiotensin system is more active in the night, because what happens is a lot of sodium is taken during the day, and it's basically a pressure natriuresis curve. The pressure increases to excrete the sodium in the night, and the renin-angiotensin system is responsible for this pressure natriuresis. So these drugs, they actually try to blunt the peak of the renin-angiotensin system if they are taken in the night, and this also protects the kidney. So I would say for patients who are taking a single drug, or who are dosed in the morning and they have CKD, it is good to shift them in the night. It is logical also. There is a lot of data supporting also. And when we have patients of advanced chronic kidney disease, I think the bottom line is to control the hypertension. Either you dose it in the night or you dose it in the day. It's very difficult to control it in the night. So that is my viewpoint. Thank you.
Thank you, Dr. Bender. We'll take some questions from the audience. And first question is for Dr. Hiramant. What is the best drug for non-dippers?
Basically, if you mean that there is a lot of vasoconstriction at night, or whatever vasodilatation should take place is not taking place for various reasons. So I would say a good dose of ACE or ARB, I would prefer ARB at night, would do the trick much better than anything else.
Thank you. I think I would agree with that. Most of the data with ARBs given in the evening has been very, very impressive, and it converts a lot of non-dippers into dippers, besides providing excellent renal protection and cardiovascular protection and metabolic protection. I agree with you. The second question is, what about elderly individuals? How many of them will get converted from non-dipper to dipper with evening dosing? That's a corollary. People are interested. You can't convert every non-dipper into dipper, because the non-dipping pattern could be because of OSA, because of a sleep pattern itself, disturbed sleep pattern, not necessarily related to obstruction. There can be central sleep apnea also. There can be drugs also. Benign enlargement of prostate can be the cause of the problem. An individual's working pattern could be the cause. So the question was, how often evening dosing will convert non-dippers into dippers in elderly?
Who is taking the question? Who is answering?
If you take age, like extremes of age, For example, younger age group, majority are having not much target organ damage. So I may start with any of the type because majority will have a dipper in the nocturnal type BP, but elderly there will be non-dippers because of the following reason. So you should be judicial while starting nocturnal BP, especially octogenarians. But otherwise, any elderly and below the octogenarians like 60s or 70s, always start with, as Jagdish sir mentioned, nocturnal BP as a role, because definitely majority are non-dippers. So it may give some sort of protection against the cardiovascular event. And in elderly, the issue is, if you take cardiovascular, we have stroke and the heart. So the reduction of the blood pressure, if you take, the benefit is with the stroke prevention rather than the cardiac like high or unstable angina. So there will be definitely big role in chronotherapy in elderly.
Okay, there is actually a case description by Dr. A.K. Day, and he wants some clues to whether he is managing this patient correctly or not. Now, listen to the case carefully. This is a 64-year male getting telmisartan 40 milligram along with amlodipine in the morning and prazosin 2.5 milligram at night for hypertension for last 5 years. Is also suffering from diabetes, benign enlargement of prostate, and also taking glimepiride 0.5 milligram, metformin 500 milligram, and for BPH also alpha-zosyn. ECG show right bundle branch blow, echo grade 1 diastolic dysfunction, HbA1c 6.8. Please suggest antihypertensive treatment is okay or not.
What is his current blood pressure?
He did not mention the current blood pressure, but he probably wants to say whether his line of thinking is correct.
Okay. If you take he's a diabetic also. If you take patient with the diabetes and hypertension, the prazosin comes only the 4th or 5th line. And
but patient is already on telmisartan and amlodipine.
Yeah, telmisartan and amlodipine. He is not added the diuretic part like hydrochlorothiazide or methyl. So the prazosin, even if it is BPH, if your primary aim is to control the blood pressure, the alpha blocker should be the 4th or 5th drug. Especially in a patient with diabetes, you should have added much more really these telmisartan, amlodipine, and third should be the one small diuretic, at least in the daytime rather than the nighttime.
Yes, I would agree with you. What I probably would do is give a diuretic, long-acting, maybe chlorthalidone or this natrilex in the morning, indapamide, and shift the telmisartan amlodipine combination in the evening, and for the timing withhold prazosin and see the benefit. If the patient behaves all right, I probably wouldn't give prazosin, but if prazosin is a good drug both for control of hypertension, BPH, and I might use it at a number 4 rather than using an aldosterone antagonist in this particular case.
Only practical issue is, since he has taken the prazosin and BPH and patient have a nocturia, he may probably, there is a chance of, the orthostatic hypotension. So you should be very careful and convince the patient that there is a chance of at least during the midnight he may have some sort of urination. Patient may have a history of orthostatic hypotension. So some practical problem is there.
Yes.
The role of SGLT2 inhibitors in his for his antihypertension. I mean, in his OHs. Will it help in hypertension?
Which one?
DAPA
or EMPA or SGLT2 inhibitor?
Definitely it will help. It is one of the good ways actually. If there is, in fact, there is a study by Kenneth Ferdinand published in Circulation last year, probably in May, resistant hypertension, ambulatory blood pressure, and use of empagliflozin. And this study has shown as much as 9 millimeter reduction in systolic blood pressure just by adding empagliflozin to the routine treatment of diabetic. So it might convert many difficult to treat hypertensive individuals to controlled hypertension, responsive hypertension by adding. So you have a very valid point. although guidelines keep saying that the SGLT2 inhibitor shouldn't be seen as anti-hypertensive drug, but Dr. Ferdinand work actually keeps telling me that there may be a role of these drugs to control resistant hypertension. I completely agree with you all and now. Let us see, there is another question which has come up in chat box. It says, what is your take on fixed combination of rosuvastatin and telmisartan in context of chronotherapy, as mostly they're preferred at night time?
See, if it is the only tablet the patient is going to take, or if it is going to help his compliance, it's perfect to use that as a combination at night, provided the blood pressure is controlled and provided the lipid levels are also controlled. Because both it comes usually in a combination of 10/40. Both of them may not be able to get the desired level. But yes, if it's available and if it suits the patient, I would be quite happy to give it at night as a single pill.
I do agree. Any comment, Dr. Ashraf?
Okay, this as Dr. Jagdish sir mentioned, true with that.
Dr. Bendre sir?
Yeah, I think, yes, sir. I think it is okay. It is prudent to use telmisartan and rosuvastatin combination. It makes a single pill in the night and gives the benefit of chronotherapy to the patient. Absolutely, it looks logical.
I have only one question. In general, in Indian patients, is the compliance difference, is there a compliance difference if they take in the morning or evening? How many people want to take in the morning and how many want to take in the evening? I just want the opinion of all three of you based upon your experience.
Yes, I am happy if this theory is not there. I will be happy in the morning. The one practical point is if he miss, he can take this tablet any time of the day. It can be afternoon or evening. But if he miss in the evening, that will be counterproductive. That was the only issue.
This is exactly in my mind.
Yeah.
I asked Dr. Hiremat to comment on that.
I feel nighttime compliance is better because usually families together, and that time I think the reminder for blood pressure medicine by the other responsible family members is overall better. So I feel compliance of nighttime dosing is better than the morning ones where everybody is in a hurry to leave or some such thing. Missing a morning dose is more common than missing a night dose.
This is a very important factor when using the oral anticoagulation. Why? Because we are insisting on the evening dose, like uniformity across the globe is 67 p.m. Probably one reason is this one, and a lot of other reasons.
Sir, yeah, I would like to give a different viewpoint here because I feel that patients, especially in this part of the country where I live in northern part of the country, they are more comfortable taking any medicine with their breakfast because if you look at diabetic patients, most of them are taking oral hypoglycemic agents, right, before their breakfast. And they really like to club their antihypertensives with breakfast, and most of they are taking some PPIs or maybe they are taking some other food supplements. They are more comfortable with taking these medicines with their breakfast, especially if they are taking nighttime medicines. They are taking some oral hypoglycemic agents before their dinner. So taking any medicine after their dinner, especially antihypertensive pills, is not very common in this part of the country.
So my own, I practice in North India, so maybe I have a different way of, I think the compliance is better if the patients take in the morning than in the evening. But this is based on my practice, and it may not be true for others' practice.
Yes.
But my patients, I have looked at it carefully. Compliance is better in the morning. Having said that, let us come to the next question. Now, Dr. Hiremat, that is straight to you. Should we give, that means, should we give ACE inhibitors and ARB only in the evening?
Preferred at night, there is no doubt. And if anything else, like if there is only one tablet, I would give it at night. And if there are multiple tablets, then it doesn't matter because anyway, the patient has to take. As an antihypertensive and for its good effect and for all that we discussed, my choice would be to give it at night.
So there is a question actually which we all can take, and I will also give you my take on that. It is, well, there is a recent case report of rhabdomyolysis with rosuvastatin and canagliflozin. Does different timing of both drug matter, or do we need to worry about single case report?
No.
We should know the subset of the case, because the rosuvastatin in a subset like our Dr. Prashant Badre's case, like CKD patient, definitely there is a, so we had to know whether what is the subset, whether diabetic nephropathy with high dose of rosuvastatin or not. A lot of other case reports also.
This case was actually rare. He had a kind of rare genetic disorder in which actually metabolism of the metabolism of the drug, actually it is not canagliflozin increasing the dose of the level of rosuvastatin. It is the metabolism of rosuvastatin which
only anti-diabetic with increasing the amputation risk. One of reports like Canvas study, there is increased reports of amputation with that drug.
Yeah, but it wasn't there in Credence, it wasn't there with 4D. So most of the people have now removed that warning of amputation actually. And so that was a pretty good, although unrelated. Here is another question. We seem to be having a lot of questions. Current place of beta blockers in hypertension management, Q7. Any volunteer to take the question? You want to take that?
The beta blockers, actually, if you take 1, 2, 3, 4, 5, it will be fine. Even below the neurocorticoid, if you take spironolactone and it's an antihypertensive, it has a very good role in even diabetic. Even ADA recommend the addition of the neurocorticoid has got antihypertensive effect, and below that only beta blocker. If you take beta blocker, the antihypertensive effect is only mild to modest, and it cannot decrease. Suppose 170, it cannot reduce less than 150 or not. So I think make it only fifth drug. And in the context of cardiovascular disease, we often give beta blocker. Otherwise, it is very, very low in the list.
Others.
The option should be in non-comorbid hypertension. Like if it's comorbid condition like angina, heart failure, it's a no-brainer. Like you have to use a beta blocker. Question is in non-comorbid hypertension. I feel in India we are underutilizing beta blockers because there are large studies now, nearly 20,000 patients, high sympathetic overactivity shown. There are other papers from Hyderabad also in the past we have shown high sympathetic activity. All the trials which are mentioned have an average age group of 65 plus. The Ascot LLA or some such trial which finished off atenolol had an average age group of 65, which is injustice to beta blockers. If you study blood pressure patient as we have from the age group of 40 to 50, in them beta blocker activity or antihypertensive activity is, I feel, very important. We are underutilizing it. We should have our own guidelines. Fortunately, we have now our own data also. So I feel our beta blocker usage should be very high up. I have used it effectively for so many decades and I continue to use it. The other aspect is many Indians develop coronary artery disease very early in their lifespan. And every patient we don't subject to treadmill tests and other things. So it's better to give them a protective medication, antihypertensive medication, provided it is controlling blood pressure. And most of the time in combination with calcium channel blocker, it makes a very good antihypertensive.
But suppose, contrary to suppose, somebody say if you are giving the high dose of beta blocker and the chance of insult, I mean, the antihypertensive had to be at least higher dosage. So the chance of insomnia and related anti-chronotropic effect.
Yes, we are aware of all this. And when we give a drug, we know the counter side also. So we'll be thinking of it if the patient comes back for follow-up. But if a patient comes back for follow-up with nothing at all, well-controlled blood pressure, then I would be happy to use the same antihypertensive.
Yeah, sir, there is one more problem with beta blockers I as a nephrologist face in my practice is then patients are having advanced chronic kidney disease and they are being put on an ACE inhibitor or ARB. and really they do not adhere to their diet, and they land up in hyperkalemia. So few patients have had already taking a beta blocker, landing into complete heart block, taking heavy doses of maybe metoprolol or nebivolol. So that becomes a complicating issue only when hyperkalemia is present. So that keeps us on our toes when we prescribe beta blocker.
True. In special subsets, you have to think differently. I'm talking of a garden variety where we are taught, all of us, bombarded by the NICE guidelines and Canadian guidelines, these guidelines that don't use beta blocker. That's why I'm talking.
But incidentally, Canadian guidelines say below the age of 60 years, beta blockers are first-line antihypertensive drugs. Indian guidelines also say they are first line in young hypertensive individuals. There are two, three quick questions, and we need to wind up and then go to the case. And I don't know the status of cilnidipine as an antihypertensive. Dr. Hiramat, okay, you can go ahead. Give your comment on that.
I have used cilnidipine to a great advantage right from its inception. I find it very smooth, not so powerful antihypertensive. So in that correct subset, if you use especially twice a day, and now that it is available in many combinations, I find it a good antihypertensive.
Good. And there is another question actually, and that this is an interesting. It says, how about taking antihypertensive drugs fasting right in the morning, early morning? I mean, prevent morning so the person gets up and takes antihypertensive drug. Any idea on that? Any thoughts?
I have done it in several of my patients just by thinking about, as I say, horses for courses. So those individuals which I feel that they would be, I tell them the first thing in the morning, as soon as you wake up, you take your antihypertensive. So by the time the drug starts working in say 45 minutes, 1 hour, the 2-hour surge is controlled by that drug. So if
good,
it's one,
I would agree with that kind of logic. If somebody is an early riser, say rising at 4 o'clock, 5 o'clock, it's a pretty good idea. I completely agree with you. And I think we have many questions, but we need to move on. And we will have a case presentation by Dr. Abhijit Tarafdar. This is a recorded case. Dr. Tarafdar has some issues, so he wouldn't be able to present in person, but we will have a discussion on this. Yes, please, case.
Will be presenting two interesting cases taken from the thesis of my student, Dr. Utkarsh Deshmukh. The first case will exemplify exactly what we mean by chronotherapy, treating hypertension in chronic kidney disease, that is CKD. And the second case is a little bit more interesting, and that I think we should keep for the end. First case, a 53-year-old male patient is a diabetic and hypertensive. He's in CKD3 with a GFR of around 48 ml, and he's on the usual treatment, statin, VHA, low-dose aspirin, and for blood pressure control, he was taking cilnidipine 20 milligram, telmisartan 80 milligram, and metoprolol 50 milligram. Whenever we used to check the blood pressure in the office, the blood pressure was under control. But he used to complain headache in the evening, occipital headache. He himself used to check his blood pressure, his systolic blood pressure in the evening and towards the night used to be high as per his record. And that is the reason we thought that we should go ahead with an assessment by ambulatory blood pressure monitoring. And this is the ABPM record. If you look at the blood pressure record, you'll find towards the evening his blood pressure tends to go up. And not only that, In early morning, we find at say 1 a.m. to 3, 4 a.m. in the morning, late night, his blood pressure shoots up. In the morning, the blood pressure, there is a surge also that is quite expected because we know that in the morning, the blood pressure normally, physiologically, there's a surge, but the problem is the rise of blood pressure at night. So there was a progressive rise of blood pressure from the evening, and the rise starts at around say 6 p.m. It used to rise quite high at night, and this is also corroborated manually. So there was two observations. One, he had an uncontrolled blood pressure starting from the evening and a rise of blood pressure at night. Please remember that normally there is a drop in blood pressure, that is a dip, and any blood pressure more than 120/70 at night is abnormal. So this patient had two things. One, he had a rise in the evening, and there is no drop at night, rather there was a rise at night. So with this, let us see exactly how the patients of chronic kidney disease behave. But before that, for your information, what we did, we, instead of increasing the dose of antihypertensive, just shifted the ARB from the morning to evening, and his blood pressure control was absolutely 280. And it was normal both clinically as well as symptomatically. The special features of hypertension in chronic kidney disease are: one, the blood pressure tends to be uncontrolled or refractory. Even 4-5 antihypertensives may not be able to control blood pressure. That is one. Second is masked hypertension. Masked hypertension is exactly the opposite of white coat hypertension. Here, what happens when we check blood pressure in a clinic, what we find is absolutely normal. But when the person goes to his normal, usual activity in his office, or at his residence, the blood pressure tends to go up. So, as if the blood pressure is masked in the clinic and it manifests in his household usual activity. Third, I have already described that the nocturnal dip of blood pressure, which is physiological, is absent in chronic kidney disease patients. And fourthly, sometimes at night, instead of drop of blood pressure, the blood pressure may rise. This is called reverse dipping or rising blood pressure. They are called reverse dippers or risers. Graphically, this is the picture that is being seen. In these patients, CKD patients, there is a tendency for systolic blood pressure to go up. Diastolic blood pressure may be normal or maybe a little less, and the pulse pressure tends to be high. And as I have already said, in CKD1, we will find very few patients have a loss of dipping of blood pressure, or hardly find any patient who has reverse dipping. But as you move forward, in CKD5, you will find more and more patients who suffer from either loss of this phenomenon or a rising blood pressure at night. That is being described in this panel, well, where you will find in the CKD stage 5, vast majority of patients are constituted by either non-dippers or risers. The same is described and demonstrated in these bar diagrams also. I will not describe them. The question is, what are the factors associated with nocturnal hypertension? What are the so-called mechanisms underneath? There are various hypotheses, and as there are too many hypotheses, it means the exact reason we do not know. Maybe abnormal sleep-wake cycle, reset biological clock, inability to handle sodium. so that the normal excretion of sodium is impeded. Elevated sympathetic tone, we discussed at length about this one towards the end of our discourse. Poor vascular compliance, sleep apnea syndrome, obstructive sleep apnea syndrome, OSA, and reduced baroreceptor sensitivity. But as clinicians, we are not interested in these theoretical aspects, why these happen and not. We are interested in what is the aftermath, what is the effect of all these abnormalities that we see in patients who have hypertension and chronic kidney disease. From the age-old ASK study downwards, we find that there are a lot of things which may happen because of this nocturnal hypertension. There may be development of new onset microalbuminuria or increase of proteinuria if there is pre-existing proteinuria. You may get left ventricular hypertrophy, myocardial infarction, stroke, and cardiovascular and all-cause mortality may be high. Study after study has corroborated this. It has been found that the riser blood pressure pattern is associated with 2.5 times higher severities and 9.6 severity death. And in hemodialysis patients also, the same thing has been demonstrated in several studies. In order to address this phenomenon, that is rise of blood pressure, which is so detrimental to the health of the individual, the approach that is being taken is called chronotherapy. By chronotherapy, this means the tailored timing of doses to match body's natural daily rhythms and behavioral patterns to increase beneficial effect or minimize adverse effects. How do we do it? There are various ways by which it is being done. The ways are, one, you can shift the antihypertensive medications, all the antihypertensive drugs to evening time. Or you can shift majority of the antihypertensives barring diuretics. Or only one or two antihypertensives may be shifted to evening time. So by chronotherapy, practically we mean shifting of one or more or even all the antihypertensives from morning time to evening. Normally, patients are advised to take all antihypertensives in the morning because that improves compliance. But in chronotherapy, we disregard this concept of compliance, but in order to address the physiological and pathological changes, that is rise of blood pressure in the evening or at night, we try to address this rise at night and shift one or more or all antihypertensives to the evening time. And there are trials also which have shown benefit. The age-old HOPE trial, where ramipril was used in the evening. The ramipril in HOPE trial was not given in the morning, it was prescribed at daytime. The significant risk reduction in cardiovascular outcome hazard ratio was 0.78. But the person who has been on this aspect of chronotherapy, his name is Armida. He is working in northern Spain, and he initially tried in the MAPEC trial, where more than 2,000 hypertensive subjects were to ingest all antihypertensive medications upon awakening, or at least one of them at bedtime. There are two lists. Patients were randomized. Please remember, it was a study where the patients were being followed up regularly. Not only that, this is a study in community. And the observation was, at the end, the participants who were taking one or more medications at bedtime were at lower risk of stroke, myocardial infarction, and CV death. The same person, Hamida, then took up another study, that is Hygia chronotherapy trial, where all antihypertensive medications were given at bedtime. In MAPEC, what they did, one or more antihypertensives were given at bedtime. And in Hygia, they have prescribed all antihypertensives at bedtime. And once again, the same advantage was demonstrated in HYGEA trial. Also to remember is in HYGEA trial, there were more than 19,000 patients and the follow-up was for 6.3 years. Excuse me. The question is, if the observations are so good, then why have we not heard of these results? The answer is very interesting, and that was given by Jarvis Varman in British Journal of General Practice in April 2017. And his answer is straightforward. This intervention has no cost, therefore there is no budget to publicize it. Not only publicizing, what about the various guidelines? If you go by the guidelines, the ADA 2019, the ESH, ESC guideline, all have considered this opinion about chronotherapy, and they have discussed at length. But while giving the guidelines, there is stoic silence. They did not spare a single sentence on guideline whether chronotherapy should be advised in patients who have a night rising type of blood pressure, particularly in chronic kidney disease patients. So we have to wait for the study, which is called time study, which is an ongoing study. More than 10,000 patients have been randomized, which will run for 5 years. And when the outcome is available, we'll be able to give you the final answer. With this, let us go to the concluding part, the second phase. This is a long story. We'll try to cut it short. The 34-year-old male, he received a kidney, he developed end-stage renal disease, and the sister was donor, renal transplant recipient. We are not aware of the native kidney disease. Native kidney disease means exactly what was the disease which had led to his end-stage renal disease. But the fact is, history-wise, he developed repeated hypertensive episodes both before transplantation and after transplantation. Though immediately after transplantation, the graft outcome, the renal function, graft function was pretty good. Within 2 years, he had repeated hypertensive episodes, uncontrolled hypertension, and he lost his graft. We received this patient in this stage when he has already lost his graft and he has already been taken for maintenance dialysis. Once again, we also found the same thing. His blood pressure remained uncontrolled and he required repeated admissions with hypertensive heart failure. And his ABPM looked like this. We'll see blood pressure starts to rise from the evening and blood pressure shoots up to nearly 190 plus late. Late means late night, early morning. And some of the readings 200. At 3 a.m. his blood pressure record is 200. Actually, we subjected this patient to ABPM on 48-hour duration because we try to see how dialysis is affecting this blood pressure control. So 24-hour on dialysis day and 24-hour on off dialysis day. And we found on both the days, the blood pressure usually used to shoot up from evening and the blood pressure would have gone up to 200, 190, 200 late at night, almost every day, whether on dialysis or not on dialysis. And as I have already said, he had repeated admissions with hypertensive heart failure. So what we did? First, we tried to go ahead with chronotherapy. And you see how many antihypertensives he was on. He was on amlodipine 10 milligram, enalapril 40 milligram, clonidine 2 tablets thrice a day, metoprolol 100 milligram, and prazosin 10 milligram. We tried to shift some of the antihypertensives, and at one point, all the antihypertensives in the evening without any success. We thought that it could be because of some other things also, as for example, this hypertension is volume dependent. So we increase ultrafiltration duration and amount of ultrafiltration with no avail. Frequency and ultrafiltration volume both increased. Then we thought, could it be a secondary cause like renovascular disease? Investigated. Nothing found. Endocrine cause, as for example, primary aldosteronism or say FEO, worked up, no avail. So we thought of what could be the cause of this uncontrolled blood pressure in this patient. As I in the beginning I have already said, there is one aspect that is sympathetic overactivity, which might operate in some of the patients. We ultimately consider that in this patient, sympathetic could be one of the mechanisms. Please remember, the renal sympathetics may be different. Different is from the center, it comes to the kidney. It stimulates renin-angiotensin aldosterone mechanism, tries to conserve sodium and water, and the hypertension is primarily salt and water dependent hypertension. So to start with its sympathetic, then RAS activation, then salt and water retention, and blood pressure rises. That is because of efferents reaching the kidneys. There are also renal afferents now more and more as we understand, realize the role of sympathetic. You know, there are renal afferents also. These afferent sympathetics, they reach medulla, and when these are stimulated, there is medullary stimulus going into the vessels, resulting in intense vasoconstriction. So renal afferents may cause severe uncontrolled hypertension when they are stimulated. And this renal sympathetics, the afferent sympathetics are stimulated in two important conditions. One, painful kidney conditions, and second, in failing kidney conditions. In this patient, the kidneys are failing, that are failed, and most likely there are renal sympathetics, afferent sympathetics, which were operating, causing uncontrolled hypertension. So we discussed with the relatives, the patient, and decided to go ahead with bilateral native kidney nephrectomy. The graft kidney doesn't have any nerve supply, so it doesn't require any affection. We didn't touch the graft kidney, but we went ahead with bilateral native kidney nephrectomy on 2 sittings. The most interesting thing is, 1 month down the line, after 2 kidneys were removed, the blood pressure gradually came down, and blood pressure could be controlled with only a single tablet of 5 milligrams of load. So this exemplifies, 1, not all cases of uncontrolled hypertension and chronic kidney disease may be managed by chronotherapy. That is first point. And second, after exclusion of secondary causes of hypertension in uncontrolled hypertensive state, one should also consider renal sympathetic afferents, and the treatment of choice at that situation may be bilateral native kidney nephrectomy in a patient where the kidneys are non-functional. We are not going to go ahead with native kidney nephrectomy in a functioning kidney, but in a patient who has lost kidney function, bilateral native kidney nephrectomy is a good choice. The other option will be renal denervation therapy. So we started with one case where we were successful by going ahead with chronotherapy, and we are concluding with another case where we could not achieve our goal to control blood pressure in a patient with an end-stage renal disease on dialysis. We could not control blood pressure with chronotherapy. Chronotherapy is a new concept, good concept, and should be applicable in selective cases where it really has its value. Thank you very much.
Excellent. I think these two cases represent two different spectra of hypertension. One first case was resistant hypertension where chronotherapy made a difference, as Dr. Harmida has pointed out. And the second was refractory hypertension. 5 drugs or more not helping. And there the pathogenesis has been thought to be excessive sympathetic stimulation, largely coming out of kidneys, and hence in non-functioning kidney bilateral nephrectomy was done. And in those who have normally functioning kidneys, one has to think of use of combined alpha and beta blockers in stiff doses to try to help these individuals. Good cases. But there is one question for Dr. Ashraf from the audience before we take your comments on these cases, and that is, in a case like CKD hypertension, would you be comfortable using benidipine plus metoprolol combination to manage hypertension?
Yeah, just before answering that question, fantastic talk by Saab as a great nephrologist. I just want to add, as a, from the cardiology perspective, also Jagdish sir also want to mention that, because many of the cases, these sort of patients, the reverse dipping happening in many of the CKD patients, there will be associated heart failure content also. In heart failure patient also, there will be nocturnal hypertension. So in a combined like cardiorenal axis, like CKD with some sort of mild heart failure will have a high reverse dipping. In these sort of scenario, the nocturnal, the chronotherapy has very, very high role. Now coming back to the question, definitely benidipine with beta blocker, but in a certain subset of patient like diabetes with hypertension and CKD, I always early CKD there will be theoretical chance of type 4 RTA like renal tubular acidosis and potential hyperkalemia, as Dr. Prashant already mentioned. So I will be a little bit skeptical by adding this. At least one calcium channel blocker and AC or ARB depends on that, the creatine clearance, and then only the beta blocker. I will first either the calcium blocker or AC ARB definitely, and then calcium blocker, then only later only the beta blocker. And majority CKD patient, the renal parenchymal disease, the pathophysiology is volume excess, not like EGFR less than 40 or 35. The scenario, I will use a little bit volume depletion, first sodium restriction, then volume depleting agent, and then only later the beta blocker. So beta blocker only the third or fourth in renal parenchymal disease, because pathophysiology is completely different. I think I
will agree with that. Actually, there is another question which any of us can take it. The question asked is, what about a fixed drug combination, or let's say combination of ramipril, atorvastatin, and aspirin given at night? Would it be more cardioprotective? Now, there are 3 drugs, different things. Atorvastatin, do we have data that taking atorvastatin evening is more useful? First, you have to talk about good data. Second, aspirin, should you be taking at night or in the morning? Last week I was in a webinar, we had a heated discussion. So I actually today morning read a lot about that aspirin business given in the evening, and I have some data. In fact, Journal of Hypertension this year, actually a few months back, carried an interesting randomized trial of aspirin given at night versus morning. But I'll tell my views, but what is your view first?
Such a combination is available, and that's why is the question. Yeah. My problem with that combination is very small doses. Ramipril is maximum of 5. Aspirin anyway, small dose, all right, but atorvastatin is always 10. So these become very inadequate in this fixed dose combination. But if somebody has to use it, it brings in compliance. It's like a mini polypill. So if somebody is non-compliant patient and this thing, then it can be used. But invariably, it will not bring in the LDL levels to normal level. So that's why, because the available combination has small doses, I won't use it. Otherwise, say ramipril 10 mg, aspirin in a good dose of atorvastatin completely at night can be very effective preventive.
You remember, Dr. Hiramat, when lovastatin was introduced to Indian market some more than 25 years back. I think it's 29 years now. People said take it in the evening because cholesterol synthesis largely, hepatic cholesterol synthesis largely in the evening. And let us take lovastatin, short-acting drug in the evening. But subsequently, when new drugs came up, this concept was given up, although some physicians continue to follow giving statins in the evening. And so your comments are required on that aspect, and also effect aspirin in the night versus in the morning.
The simvastatin also carried the same kind of a warning that use it at night because the maximum production of cholesterol is at night and it is short acting. But for atorvastatin onwards, no such restriction is there. You can use it any time of the day and it will be as effective. Ramipril, anyway, HOPE trial used at night, so one would be using at night. Regarding aspirin, I have no specific thoughts. I mentioned in my talk that when they studied along with, as a part of chronotherapy, they studied aspirin taken any time of the day, it was as effective. Obviously, you have something up your sleeve, so let me know that.
No, I just read a few randomized trials suggesting that there have been some studies which have suggested that giving aspirin in the evening augments the antihypertensive efficacy of other drugs. And given alone, aspirin in the evening can cause as much as 6 millimeter decrease in systolic blood pressure per se as an antihypertensive drug. However, I was lucky to actually go through some of the randomized trials published in Hypertension this year, and these negate that previous concept that that aspirin in any way is an antihypertensive given in the evening or augments antihypertensive efficacy of other drugs. That is all I have read. What about antiplatelet efficacy enhanced at night? I haven't seen any data, but maybe next time when this question comes up, I will go through the literature once again.
No, I have read this one-liner today for this chronotherapy talk that when they studied other drugs for chronotherapy, aspirin had no effect. Given any time of the day, it was as effective.
Yes. I think we had a fantastic discussion, and I think this is a time to close. But there is a last question. What about combination of diuretic and amlodipine at morning? Diuretic and amlodipine in the morning.
I want to put it the other way. Obviously, if there is a diuretic, everybody thinks of a morning dose. But if you listen to Bacris, who is now considered almost American father of hypertension, he is very pro giving diuretics at night because he thinks the doses that we use, maximum to 12.5 of hydrochlorothiazide, 1.5 of indapamide, and chlorthalidone 12.5, they are hardly diuretic doses. And after a few maybe days or weeks, they start behaving like vasodilators. So don't be shy to use it at night if it comes to using at night. But amlodipine also causes some diuresis, and it would be prudent, more common sense based to at least start in the morning time. And it would be typical therapy for isolated systolic hypertension in an elderly man. That would be the combination of choice started in the morning.
Yes, I would agree with you. I actually use eplerenone or spironolactone more often in the evening, and my thinking actually in that aspect as a fourth line antihypertensive or as a anti-failure drug is that aldosterone levels are higher at night, and the drug should work better. But then again, we have no data on that. It is just thinking. You know, we physicians practice a lot of it, what we call as practice by sixth sense, visceral conviction. And it works a lot of time, it may not work other times. But nevertheless, I think we need to give respect to sixth sense. That comes out of experience and we all should respect it. And when you have certain views, I actually thoroughly respect it. Yes.
What we learn from books and guidelines is science of medicine. And what we practice for the benefit of the patient is art of medicine. And beyond that, there is always commerce of medicine.
Yes.
Yeah, and the
Commerce and common sense also. Commerce and common sense also.
Commerce is a bad sense.
Yeah.
I would like to add, sir, one point here. Dr. Swapnil was just mentioning about chlorthalidone and Dr. Bakris. So there was one paper Dr. Bakris has published about use of chlorthalidone in advanced renal failure. Because chlorthalidone is a weak diuretic, it does not work when the GFR goes below 30. And he used chlorthalidone in those patients who had a very low GFR. Even in those patients, he was able to show a reduction in blood pressure. So this goes on to show that chlorthalidone does not only act as a diuretic, but it also acts as a vasodilator. So this was just to share that paper which was published by Dr. Bakris. Yeah.
Dr. Bendre, I'm not sure this paper belongs to Dr. Bakris. This is a paper written by Dr. Rajiv Agarwal.
Okay, yeah, I may be wrong about
and
that.
he's himself a big nephrologist. I had a chance to actually listen to him, and when he presented this paper, and he used it up to an EGFR of 20, and he said it works beautifully up to the EGFR of 20. So it's not Dr. Bakris, it is Dr. Rajiv Agarwal. I just wanted to correct it because I know some story behind it. Thank you very much. Amit, the floor is yours. You can now actually wind it up.
Thank you, Professor J.C. Mohan, sir. I think it is time to say a vote of thanks. And on behalf of Zenith Division of INTAS, I would like to offer a vote of thanks. First of all, I would like to thank all the delegates who have joined today, taking their time off from their busy schedule. And I hope they have enjoyed the academic feast delivered by the eminent faculties today. I must thank Professor J.C. Mohan for guiding us in organizing Practice Pulse in Hypertension. I would thank Dr. Jagdish Hiremat, Dr. Abhijit Tarafdar for their lucid presentation. I would thank Dr. Prashant Bendre and Dr. S.M. Ashraf for making this program truly interactive. Practice Pulse in Hypertension is a monthly program on hypertension which is being organized on second Saturday of every month. Please do join us for our next program on 12th of September 2020. We will again have Professor J.C. Mohan guiding us, and I'm sure he is going to give us another virgin topic which all of us are going to be enjoying. And in the end, I would request you, this program is sponsored by Zenith, which is a maker of makers of Silni and Allmark. I would request you kindly support us for these two products. So I must thank all of you once again, and thank you very much for your kind presence here. Thank you.
Thank you, Amit. Thank you.
Good night to all of you, sir. Good night. Thank you. Thanks for your available time. We had around 1,300 doctors today, sir, who were